I wish our patients that we see had no comorbidities, but these patients are older, right? That maybe they're on, maybe they have heart failure, maybe they have coronary artery disease, maybe they have AFib and they require Eliquis and a blood thinner, right? Or Pradaxa. So what do you do in your practice? Because we have abiraterone, we have darolutamide, we have enzalutamide, and how do you decide in terms of the patient characteristics and the comorbidities and which treatment you give?
Right. So that's also a very tough, right, decision to make. So if they have a very strong cardiovascular disease underlying, definitely to kind of have a cardio-oncologist on board, I think that's will be also important. In terms of which hormone therapies, which ARSI or abiraterones, so I mean all the hormones kind of cause like diabetes, like the risk for diabetes, high blood pressures, and I think long term there's already some risk of cardiovascular disease, and I don't think we can avoid. There's no like one good options for that. I think abiraterone might have a little bit of high chance of having cardiovascular disease. And there is a meta-analysis reported at the ASCO that the age, right, like age over 70 or 75 tend to have less benefit with the abiraterone, and more so with the ARSI. So, and I think similar data kind of presented with the VA population, kind of they found the same thing. So, and with that having high risk with the abiraterone, so I might try to avoid that.
Yes.
And in general, I think we're still trying to learn the darolutamide. However, I think we with the experience, they tend to have a better tolerable, like fatigue, and especially like less CNS penetrations and less seizure risk and dizziness and all these. So I think for elderly populations, darolutamide might be a better choice, and also the drug interactions. Enzalutamide has and also the apalutamide has a very strong CYP inhibitors. So I think darolutamide tend to have a more favorable, all these safety and side effect profile. In terms of cardiovascular, I'm not quite sure, enzalutamide, which one has a less cardiovascular risk. So.
Yeah, outstanding points. I know that was a stopgap data at ASCO GU where they looked at patients above 75 and they pulled these patients. And what they found, as Dr. Myint said, is the patients that received abiraterone, there was no overall survival there. And including the VA study, that puts those patients at higher risk. So abiraterone is like being less and less for these older patients. And then you brought up another great point, Dr. Myint, is the patients that have other comorbidities such as atrial fibrillation. Our patients see cardiologists and they get put on an Eliquis or Pradaxa, and pop-up jail, right? We have Epic, right? We put like enzalutamide or apalutamide, it just jumps up and it says drug-drug interaction. And so if you're brave, you double click, but what it does is it lowers the Eliquis and lowers the Pradaxa dose. And so then the pharmacist calls and says, do you really want to do that? You do that like 6 or 7 times in a week, they're like, I don't know if I want to get that call because it puts a patient at risk. So, but darolutamide, you don't have that risk. So I think that's the thing that I kind of think about. Travis, what are your thoughts about patient factors or comorbidities?
Yeah, I think all those points are exceptional. I think I agree that I think the older somebody gets, I think abiraterone gets more challenging. Obviously, underlying diabetes and the prednisone requirement can be challenging as well. I think darolutamide is very compelling because of less CNS penetration. Has a different backbone. It's not really, the other two sort of resemble benzodiazepines and darolutamide doesn't. So I sort of primarily prefer darolutamide just for sort of ease of use, less epic warnings, unfortunately, is all part of that. There's an upcoming ARCOG trial to sort of look at combining sort of formally in a prospective manner enzalutamide and darolutamide in terms of fatigue and and conditive effects in our population. I'm curious to see what that's going to show,
Yeah.
but hopefully shows positive results.
Absolutely. I'm all for real-world studies that are prospective because you'll have those real-world evidence of darolutamide, enzalutamide, but it's a retrospective study. Sometimes with the apalutamide, with abiraterone, that's a retrospective study. But prospective studies, that's what really kind of
Sure.
moves the needle. Ryan, any other thoughts in terms of this field, in terms of darolutamide, apalutamide, enzalutamide? We talked about insurance coverage. We talked about patient factors. Any other factor that kind of drives your decision?
One of the nuances going back to the cardiovascular risk is maybe the ADT selection and
Yes.
maybe considering intermittent ADT. There's some trials looking at monotherapy or intermittent ADT along with an ARPI. So I think that data is going to be really interesting to see if there's a signal there to be more protective for the cardiac patient.
Absolutely. Vikas?
Yep, so I just wanted to add that darolutamide is a great drug, great safety profile, but the ARNOTE study it still doesn't have the OS data yet. So if I were to pick a doublet, I would still stick with abiraterone, Erleada, apalutamide, or enzalutamide. But if I'm picking triplet, then I, of course, lean towards darolutamide. I mean, unless looks like darolutamide will be a positive study, but I think we'll have to wait for some more follow-ups.
Yeah, it's like the Kentucky Derby. It's like instead of all the horses starting at the same time, you have one horse that starts 5 minutes or like we would say 30 seconds early. The other one's like 20 seconds, and then you got the last horse. So you're right. It's like we can't really say. And then the other thing is, since the study was done in a different location, they actually unblinded the study to help out the patients because they weren't allowed to actually just continue with ADT alone. So they unblinded the study. But you raise a fair point. Any other thoughts?
And just to add to the ARNOTE study, it was 2-to-1 randomization because a lot of doublets were already on the market, and it was not right for the experiment, the control arm to be just single agent ADT.
Yes.
So yes, their interim OS survival is not significant, but it will be hard to get overall survival just because the time where the study was designed and the way it was designed. So we'll see what it is, but I feel like just the way the drug works, it's similar to enzalutamide, Erleada. So I am using darolutamide quite often as a doublet as well.
Yes.
And
Any other thoughts?
Just to add one thing for cardiovascular risk about the ADT choice, there's also Ogovex right on the market, and per HERO study, Ogovex tend to have a lower risk for cardiovascular side effects. So I tend to use a lot for those patients. If they have an underlying diabetes, hypertension, family history, or personal history of cardiovascular, I tend to use Ogovex.
That's a great point, because that's the cardiovascular risk. And, it's kind of hard to have a true, real comparison. But if you look at the non-metastatic castration-resistant prostate cancer patients, where you had the Aramis study and you had the Spartan study, and those studies were very similar in design. And the PFS and the OS was very similar there. Yeah. That's the only caveat I would kind of throw out there. Even though darolutamide is structurally different, the PFS and OS was very similar to the other two. And that was all in the US, across the world too.
Even in all this metastatic castration-sensitive phase trials, if you look at rPFS, their hazard ratio, everything is 0.4 to 0.5. I mean, they were very tight windows. So, I mean, all the drugs, efficacy-wise, they seem to do the same. It's each side effect profile, each one has some nuances to it.
Sure.
Which one we need to pick one for the right patient.
Absolutely.